Hey guys, Nick here, and welcome back to another section of the respiratory chapter. Let's shift our discussion now to talk about respiratory pathology. The first topic in respiratory pathology is in the upper respiratory system, the sinuses. Now, rhinosinusitis is likely a familiar condition for you. Here, there is an obstruction of sinus drainage into the nasal cavity. The patient will feel all stuffed up because they are exactly that. Take a look at this image. Here you have a non-contrast CT of the sinuses. You can see that the right maxillary sinus is filled with fluid. Where is the most common site of sinus inflammation? Correct, the maxillary sinuses. Do you remember from anatomy why that is? The drainage orifice of the maxillary sinus is superiorly placed near the roof, impeding drainage. Now, what's the most likely cause? Usually a viral upper respiratory infection. However, once a patient has a viral infection, a superimposed bacterial infection can occur. Now, what are the most common bugs? Well, they're the same ones that cause otitis media: strep pneumo, H. influenza, and Maxarella catarrhalis. Knowing these bugs for this condition will make you look like a rock star in your pediatrics rotation. Now let's talk about epistaxis, or nosebleed. About 90% of all nosebleeds are anterior nosebleeds because it's in the anterior portion of the nasal airway that will become most dry during inspiration. This dryness can weaken the blood vessels in that area and predispose someone to developing a nosebleed. There are 4 arteries that anastomose in the antero-inferior part of the nasal septum. This is called Kesselbach's plexus. One of these 4 anterior arteries, the sphenopalatine artery, which is a branch of the maxillary artery, may actually bleed in the posterior segment of the nasal septum and cause a life-threatening hemorrhage to occur.
The lining of the upper aerodigestive tract is mostly of the squamous cell type. Therefore, most of the cancers that arise in the respiratory tract of the head and neck will be squamous cell carcinoma. Classically, tobacco and alcohol have been the 2 biggest risk factors for head and neck squamous cell carcinoma. The HPV-16 serotype is thought to contribute to the pathogenesis of the oropharyngeal type of squamous cell carcinoma. EBV has been implicated in the pathogenesis of nasopharyngeal carcinoma. A certain concept of carcinogenesis in the head and neck that's important to be aware of is what's called field cancerization. This term describes a situation when a certain carcinogen, i.e. tobacco, damages a wide range of the superficial mucosa in the respiratory tract. Multiple tumors can thus arise in this region secondary to the wide range of tobacco exposure. This image is an indirect fiber optic exam of the larynx, which demonstrates a mucosal mass on the laryngeal side of the epiglottis, likely representing a squamous cell carcinoma. What's the next step? A direct laryngoscopy and biopsy.
Deep venous thrombosis, affectionately referred to as DVT, is very high yield because it's the primary cause of pulmonary emboli, which we'll talk about next. Here you see a picture of a DVT that is erythematous, swollen, and most likely painful. The development of a DVT most commonly occurs via Virchow's triad. Do you remember what this triad is from your hematology series? Sure you do. Patients are predisposed to the development of DVT on the basis of venous stasis, hypercoagulability, and endothelial damage. In other words, you're getting an inappropriate activation of the coagulation cascade. So what types of case presentations on the boards make you think of DVT? Well, classically you want to think about an orthopedic trauma patient, or really any patient who's been immobilized for a long period of time. Other folks at risk include older patients, women who are pregnant or who are in the postpartum period, people who are taking long plane trips or car trips, cancer patients, and women on birth control pills. Basically, anything that leads to either stasis or creates a procoagulant environment in the blood. On the exam, you might be given a patient that presents to the clinic with complaints of a painful, swollen calf without any history of prior trauma to the area. The stem will describe a long car ride or an overseas flight that the patient just arrived from a couple days ago. In this case, the stem is trying to describe for you an instance of venous stasis, which, as we know, can predispose someone to the development of a DVT. In addition, there are many autoimmune disorders that can alter the coagulation cascade. Do you recall from the musculoskeletal section which autoimmune disease can result in hypercoagulability? Lupus, the great imitator. Homan's sign is tenderness of the calf muscle with passive stretching such as dorsiflexion of the foot, and can be an indication of DVT. However, Homan's sign is usually not very sensitive or specific. In fact, many DVTs are totally asymptomatic. Because of this, you usually try to make the diagnosis with duplex ultrasound of the extremity in question. Now, how would you treat a DVT? Patients with DVT are commonly treated with heparin, low molecular weight heparin, and warfarin. This keeps the clot from expanding and greatly reduces the chance of a pulmonary embolus. This venogram is from a 15-year-old girl who's taking oral contraceptives whose left leg became severely swollen after a long airplane ride. As you can see, there is complete obstruction of the proximal left femoral vein, propagating into the distal IVC with multiple dilated collateral vessels. Name 3 major contributors to DVT formation. Venous stasis, hypercoagulability, and endothelial damage, which is the Burkhouse triad. The topic of pulmonary emboli is a classic boards and clinicals topic. You'll talk about this all the time as a third-year student with any patient who has sudden onset of dyspnea, chest pain, and shortness of breath. Oftentimes, the only findings will be tachycardia and hypoxemia, so keep pulmonary embolus on your differential. Now, there are a number of things that can embolize to the lung arterial vasculature, and that's pretty well summarized here by the fat bat mnemonic. Fat, air, thrombus, bacteria, amniotic fluid, and tumor all may comprise pulmonary emboli. Now, do you know what fat emboli are usually a result of? Correct, long bone fractures and liposuction. Now, all these patients have hypoxemia, neurologic abnormalities, and a petechial rash. This is an H&E stain of a blood vessel in the lung. The patient died of a massive fat embolism after an ERCP that resulted in pancreatitis. Now, if a woman presents just after delivering a baby with stroke and shortness of breath, what should you be thinking? Amniotic fluid emboli, which, in addition to pulmonary embolus, can also lead to stroke, an anaphylactoid reaction, and DIC. So what is DIC again? Well, disseminated intravascular coagulation is widespread activation of the clotting cascade leading to bleeding, bruising, and kidney failure. The classic tip-off on any boards question is blood oozing from all IV sites. Now, this peripheral blood smear shows peripheral blood schistocytes and helmet cells in a patient with DIC. Now, that being said, most pulmonary emboli arise from deep vein thromboses in the legs. You should know that although most DVTs occur in the calf, they don't always embolize. The most common site of embolization to the lungs is from the deep femoral veins. Now, this patient has a DVT in which vein? The iliac vein, that's correct. Here is a pulmonary embolus that came from a femoral DVT in a 60-year-old male who presented with sudden death. Now, this is a massive saddle embolus blocking the pulmonary artery, so you can see why this was a fatal event. You can see that the clot was formed sometime prior to death with the lines of Zahn, where you have pale layers of platelets mixed with fibrin, alternating with darker layers containing red blood cells. The first step in diagnosing a pulmonary embolus involves having a high degree of suspicion. In the ER, you usually won't see too much with a chest X-ray or an EKG, so a CT angiogram for visualizing the pulmonary vasculature is the test of choice. Flash quiz. Where is the most common site of origin of pulmonary emboli? The femoral vein, even though the most common site of DVT is in the calf. So here's another huge topic for board exams, and it's a big group of diseases in general. How big, you ask? Well, COPD alone kills more than 125,000 Americans each year. To understand obstructive lung disease, it's important to understand forced vital capacity and forced expiratory volume in 1 second. Do you recall what volume of air the forced vital capacity measures? It's the volume of air that can be forcibly exhaled in 1 full expiration. The patient is asked to inhale as much as possible and then exhale as much as possible. When I see FVC, I always think of the C standing for candle, because if you're going to blow out a bunch of candles, you want to inhale and exhale as much as you can. FEV1 is measured in a similar way, but is only the volume of air that can be exhaled in the first second. In a normal person, how much air should they be able to force out of their lungs in 1 second? About 75 to 80% of the total lung volume. By definition, obstructive lung disease involves obstruction of airflow with air trapping in the lungs. During exhalation, the airways close prematurely at higher lung volumes than normal, thus resulting in an increased residual volume and decreased forced vital capacity, since less air is able to leave the lungs. Think for a moment about the diagram of lung volumes we went over in lung physiology, and think about how obstructive lung disease would affect those lung volumes. Pause the video for a second if you need to. We'll talk about this a little later when we compare obstructive with restrictive lung disease. Now, FEV1 decreases as well. Less air is exhaled in the first second of forced expiration. Since FEV1 decreases to a greater extent than FVC, the ratio of FEV1 to FVC drops, which is a hallmark of obstructive lung disease. Since these patients also have decreased ventilation due to a lower vital capacity, they have decreased ventilation and increased perfusion, or a VQ mismatch. So let's discuss COPD, asthma, and other forms of obstructive lung disease. Patients with chronic bronchitis can be thought of as blue bloaters. This is one of the more common types of COPD. Now, what's the underlying pathology? The pathology of their disease involves hypertrophy of mucus-secreting glands in the bronchioles, which can be quantified with a Reed index greater than 50%. Now, what's a Reed index? Well, it's the ratio of the thickness of the gland layer to the total bronchial wall thickness. The mucus and inflammation causes the obstruction, which causes the body to decrease ventilation and increase cardiac output, creating that VQ mismatch. You may also see secondary polycythemia as the body attempts to compensate for poor oxygenation.
Now, how will you know a blue bloater? Well, these patients classically present with a chronic cough for greater than 3 months per year for at least 2 years. They also have wheezing, crackles, and cyanosis from shunting, and dyspnea on exam. You might also see signs of right heart failure, also known as cor pulmonale, which gives them that swollen, bloated look.
Flash quiz. What happens to FEV1 in obstructive lung disease? It's decreased. When you think of emphysema, and also of chronic bronchitis, what's the very first thing that should come to your mind? Tobacco smoke. Now, how could the patient be described on general exam? Barrel-chested and breathing through pursed lips. So, with smoking, you get this characteristic destruction of airways and the terminal bronchioles, classically called centri acinar, before spreading peripherally. This leads to decreased recoil and increased compliance in the lungs, often presenting with signs of dyspnea, decreased breath sounds, tachycardia, early onset dyspnea but late onset hypoxemia, and eventually wasting. The pink puffer look comes from the effort to puff through pursed lips to increase airway pressure and prevent airway collapse during exhalation. Other morphologic types of emphysema are pan-acinar, caused by alpha-1 antitrypsin deficiency. This disease is extremely board testable, so please know it. Normally, what does alpha-1 antitrypsin do? Well, it inhibits neutrophil elastase from breaking down elastin. So no alpha-1 antitrypsin means more breakdown of elastin in the lungs, which leads to pan-acinar emphysema. Alpha-1 antitrypsin deficiency is defined as a mutation resulting in the misfolding of the A1AT enzyme, leading to the enzyme's subsequent buildup in the hepatocytes because it cannot be released effectively. This causes damage to the hepatocytes and will also cause liver cirrhosis. When should you think of alpha-1 antitrypsin deficiency? Usually in a young patient with liver and lung problems, or unexplained emphysema with liver enzyme abnormalities. Now, that being said, patient with alpha-1 antitrypsin deficiency should still avoid smoking because it can worsen the pan-acinar emphysema. Now here's a picture of a patient's bronchiole who has asthma. Note the mucoid exudates in the lumen, the goblet cell metaplasia, and the epithelial basement membrane thickening. So how is asthma different from COPD? Asthma is classically caused by bronchial hyperresponsiveness leading to reversible bronchoconstriction, whereas in COPD, the obstruction tends to be fixed. Now remember, there's a spectrum of diseases where you can have a bit of overlap between the two conditions. The classic pathology associated with asthma is smooth muscle hypertrophy, airway inflammation, and mucus plugging. Kirschmann spirals are shed epithelium that's a byproduct of mucus plugging. You can see the obvious corkscrew shape here. So if you looked at the sputum of an asthmatic patient, what else would you see? Well, you might also find Crayola bodies, Charcot-Leyden crystals, and of course eosinophils, especially in allergic asthma. Now what do eosinophils do in asthma? Eosinophils release major basic protein, which causes epithelial cell damage and bronchospasm in asthma. In allergic asthma, you'll also see Th2 cytokines like IL-4, 5, 10, and 13. Now if you don't know which cytokines drive allergic inflammation, go back to the immunology section for a quick review. The findings of an asthma exacerbation are cough at night, wheezing, dyspnea, and tachypnea. Now how would you diagnose asthma? With a methacholine challenge, which is addressed in the pharmacology section. Now finally, do you know what type of hypersensitivity allergic asthma is defined as? Type 1. Now this is definitely high-yield material for the exam. Knowing the hypersensitivity types and the mechanisms by which they can manifest is a commonly tested topic. Now can you recall any other type 1 hypersensitivity reactions? Allergic rhinitis, conjunctivitis, anaphylactic reactions, and urticaria or hives, just to name a few. Now this is again covered in much more detail in the immunology chapter. Finally, we come to bronchiectasis, which is a permanent, irreversible dilation of the proximal and medium-sized bronchi. This condition may present with purulent sputum, recurrent infections, and hemoptysis. Causes of bronchiectasis include necrotizing infections with bugs like staph and Klebsiella, bronchial obstruction, and allergic bronchopulmonary aspergillosis. You can see this in conditions with poor ciliary motility, cartilaginous syndrome, and cystic fibrosis. Here's a chest x-ray of a cystic fibrosis patient with bronchiectasis. You can see scarring and mucoid impaction. Note that he has a relative sparing of the left lower lobe. Now this is a coronal CT in a patient with recurrent and chronic pneumonia. You can clearly see the dilated bronchi, especially on the right side. Flash quiz. What does alpha-1 antitrypsin inhibit? Elastase in the lung. So we've discussed obstructive lung diseases. Now let's talk about restrictive lung disease. As you'll remember from our discussion of different pulmonary function tests, restrictive lung disease has a characteristic pattern. As a result of restricted expansion, lung volumes such as FVC and TLC are decreased. But what happens to the FEV1-FVC ratio? Well, unlike obstructive diseases, the ratio is usually preserved because patients don't typically have any problems emptying their lungs. They really just have less volume to exhale. It's useful to think of restrictive lung diseases in a couple ways. First, think of the mechanics of breathing and the different components involved that aren't the lungs themselves. Can you recall a handful of diseases that result in systemic muscular weakness? Poor muscular effort in such conditions as polio and myasthenia gravis result in restrictive lung disease. Similarly, conditions that physically restrict the volume capacity of the lungs, such as scoliosis or morbid obesity, which is one of the most common causes, also fall into the restrictive lung disease category. Now, which category would osteoporosis with a Dowager's hump fall under? Good, the second category, meaning restricted volume due to the structural apparatus. Interstitial lung diseases, which affect the lung parenchyma, are restrictive lung diseases that also negatively impact the diffusion capacity of the lungs. So how do we measure diffusion capacity? Remember in the respiratory physiology talks, we said that carbon monoxide is a gas that is diffusion limited. In other words, this gas equilibrates slowly across the alveolar capillary membrane in the lungs and is not affected by cardiac output, unlike nitrous oxide, which is perfusion limited. So in this test, we ask patients to breathe an air mixture with a small amount of carbon monoxide. Then we measure how much carbon monoxide is taken up by measuring the exhaled breath. The result is expressed as a percent predicted DLCO, which stands for the diffusion capacity of the lung for carbon monoxide. A low percent predicted value would indicate a diffusion problem that would affect oxygen uptake. Examples of interstitial lung disease include idiopathic pulmonary fibrosis, acute respiratory distress syndrome, and neonatal respiratory distress syndrome, which we'll discuss shortly as we go through the pneumoconioses. Now there's also a long list of drugs that causes direct lung toxicity, fibrosis, and restrictive disease. Here's a case of pulmonary fibrosis caused by amiodarone toxicity. Note the fine reticular nodular pattern on the chest X-ray. This is the typical look for most of the interstitial lung diseases. Let's take a look at some final lung volume comparisons to make sure we solidify these two types of lung pathologies in our heads. Now, in a normal lung volume curve, as discussed previously, our FEV1 to FVC ratio will be about 80%, meaning that the air that we can forcefully blow out in 1 second will be about 80% of the total air that can be exhaled maximally. In obstructive lung diseases, both the FEV1 and FVC volumes are decreased, as is the overall FEV1 to FVC ratio. And finally, in restrictive lung diseases, both the FEV1 and FVC volumes are decreased, but the ratio between the two is preserved and may actually increase. Obstructive lung conditions, as you can see here, have lung volumes that are higher than normal because of air trapping. Specifically, total lung capacity, functional residual capacity, and residual volume are all increased in these conditions. So how would you contrast this with restrictive lung diseases? Well, obviously you can see a big decrease in lung volumes. Now that being said, there is a comparable reduction in both the FEV1 and FVC, thus resulting in the FEV1 to FVC ratio being at or greater than 80%. Note, however, that total lung capacity in restrictive lung diseases is dramatically reduced, and the volume curve is shifted down relative to normal lungs.